Okay, moving into the foot and ankle for prevention and assessment of injuries. So, going over basic overview, it's highly vulnerable because we use our foot in so many different ways, and its repetitive stresses and strains can be happening at any point in time. It can be instant or acute, or it could be chronic and occurring over a long period of time. Also, there are situations or ways to reduce the chance of injuries, and that's strength training, stretching, neuromuscular training, proper footwear, and preventable ankle bracing or taping. So when we talk about prevention, so we want to talk about selecting appropriate footwear, using a proper shoe orthotic if needed, paying attention to appropriate foot hygiene and care, as well as proper Achilles stretching. When we talk about footwear, when I say footwear, we're talking about running shoes or different shoes. So depending on what you're doing, you need to have the proper shoe for it, be it a cleat, be it a running shoe, be it a tennis shoe, be it a basketball shoe. They're all slightly different for different reasons and different goals. So you should have a separate pair of shoes for each sport. So you shouldn't have one shoe that you wear to every practice for every different sport. You want to make sure the toe box has enough room. I know a lot of people with cleats, especially for soccer, they like them super tight and shorter. But if you want to, your regular running shoes or conditioning shoes, you want them longer. You want to look at how they're formed. Are they high tops, low tops? Different shoes apply for different things. So the form of the shoe could be straight, should be semi-curved or curved. And when we want to look at it, we're looking at shock absorption of the sole. Okay, so there's 3 layers typically in a shoe. There's the thick spongy layer that absorbs the force under the heel. Then there's the midsole that has the cushion for the midfoot and toes. And then there should be a hard layer that is on the bottom that comes in contact with the ground. So depending on your type and shape of foot, it's depending on what type and shape of footwear that you might need. For a flat foot, you want a straight shoe, run on the inside of the foot, or a pronator. If you are a normal foot, normally you need a semi-curved or a high arch. You want a curved shoe that you run on the outside of your foot typically. So when we talk about orthotics, we're talking about these correct biomechanical problems. So if you are a pronator or if you are a supinator, depending on the spectrum, you may need some type of orthotic or insert. There's all different types. There's the super cheapo ones to super expensive and fitted to you, casted to you through the doctor. All of them are good. It just depends on the need and depends on what works for you. Some people swear by Dr. Scholl's and they just keep buying Dr. Scholl's and it works for them. I personally really like the sole orthotics because you heat them up in an oven and then you put them in your shoes and you stand on them and they form to your foot, and then they also give you support. But you also may need a custom one depending on your situation, depending on how significant your need is. Foot hygiene. I know it sounds silly, but if your toenails are messed up or you have excessive calluses, that can hinder your feet and your running because you can cause ingrown toenails. And as silly as it sounds, if you get a bad enough ingrown toenail, it prevents you from participating. You can't put a shoe on. You can't do different things. So you want to prevent athlete's foot. You want to wear dry socks. You want to wear clean socks. You want to wash your feet. Sounds silly, but it is a thing. Also, we want to stretch our Achilles tendon. The ankle needs to dorsiflex at least 10 degrees to have normal gait pattern. So when we walk, our ankle has to be able to flex 10 degrees. If we have a tight Achilles tendon, it's going to limit that dorsiflexion. And those with a tight Achilles tendon are more prone or predisposed to ankle injuries. So we want to stretch with the knee in full flexion. I'm sorry, not knee in full flexion, in flexion 15 to 30 degrees, and also in full extension. So when you stretch your calf, you want to stretch with your leg completely straight and then with a slight bend in your knee. When we talk about stretching our calf, we're talking about propping our heel on the ground and putting our toe up or hanging off a staircase or a curb, something like that. Also, there's ankle taping or orthosis, which means bracing. So tape properly applied can provide some prophylactic protection. However, there are negatives to tape. Tape loosens. Tape, also done incorrectly, can constrict the normal biomechanical functions of the ankle. If anyone's ever had their ankle taped, you may feel that you can't dorsiflex your ankle that 10 degrees to have normal gait pattern. So there are concepts that people prefer bracing because it can be adjusted and also allows for more movement. So lace-up supports are ideal, as well as semi-rigid options. So personally, I like the ones that lace up because they can change how tight they are, as well as there's a crossover crisscross strap. Now the semi-rigid ankle braces, so those are what we think of when we talk about like the ones in the middle, the air casts or the active ankles. Those can mess with your biomechanics of the ankle and the knee joint as well, because it removes all movement. The ones on the left, the ASO ones, those are the ones I personally like. They lace up and they cross over. It's very similar to taping, but it can be adjusted and last longer. Taping does not last that long. Now, when we're looking at a foot or ankle injury, we're going to have to look at all different aspects of the lower leg, ankle, and foot. They're all connected. So our first thing is we're going to start, like every eval, we start the same way. We start with history. So history. So you're going to ask the same questions. Now there's going to be slight changes depending on the body part, but all the history questions should be pretty much the same no matter what you're asking. How did it occur? When did it occur? How did it feel? Where's the pain? Type of pain? Muscle weakness? Was there sounds? Can you pinpoint this spot? The things that would be specific to this would be footwear or training regimen. Now, then you're going to go into observation. Remember the O of hips, hops. Observation or inspection. Are they favoring that foot? Are they walking with a limp? Are they not walking at all? Is there a deformity? Is there swelling? Is there ecchymosis? Is it pes planus or pes cavus? High arch or low arch? Are there abnormalities to their toes? Are there shoe wear patterns? Do you have ankle range of motion? What's their walking pattern like? These are all things that you're going to look at and not necessarily tell the athlete or patient that that's what you're looking for, but you're going to write it down as part of your evaluation that you observed these things. Then you're going to go into palpation. Remember the P. So first we do bony, right? We have to rule out fracture and we want to compare bilaterally. So when you're looking at the foot, you're going to start with bony palpation first, and you're going to palpate the main bones, the calcaneus, medial malleolus, lateral malleoli, the talar head, navicular, cuneiforms, the metatarsals, the phalanges, the sinus tarsi, and the sesamoid bones, and the cuboid. You're going to go through all of that. Then you're also going to palpate the ankle. Same concept. You're going to look at the fibula, the lateral and medial malleoli, the tibial plateau. I realize it's higher up, but you got to check it. The tibial shaft, the talus, the calcaneus, and the navicular, all part of the ankle. Then you're going to go to soft tissue. So all these are the soft tissues, the muscles and the ligaments, a part of the foot. So we got the posterior tib, the anterior tib, flexor hallucis longus, flexor digitorum longus, the deltoid ligament, the medial longitudinal arch, the plantar fascia, transverse arch, ATFL, CFL, PTFL, perineals, extensor hallucis longus, and extensor digitorum longus. Palpation of the ankle. So now we also need to check the ankle part. So notice these are very similar, okay? We're checking all the similar things, but we're going to add the extensor, hallucis longus, extensor digitorum, the gastroc, the Achilles, the soleus, and the perineals. You're also going to check pulse. You want to make sure that there's proper circulation. So we're going to check the posterior tib artery and the dorsalis pedis artery. The posterior tib artery is right behind the medial malleolus. It's about 1 inch in front of the Achilles tendon. And you can palpate right there, and you're going to feel the pulse, just like we did in our wrist or our carotid. Dorsalis pedis artery, it's the medial and lateral malleoli proximal to the end of the first intermetatarsal space. So, to know where that is, you're going to kind of lift up the foot against resistance, and you'll feel that right in between the medial and lateral malleoli in the intermetatarsal space. So basically in the middle of the foot in the intermetatarsal space.